slavery, to childhood experiences of abuse and neglect, and faults, and even social determinants of health can be experienced as traumatic. So homelessness, food insecurity, economic instability. Another form of traumatic stress is secondary traumatic stress, which is a set of symptoms nearly identical to PTSD that are the consequence of caring for a person who has been traumatized. For instance, a medical provider who takes care of someone who has just been the victim of a violent crime and then goes on to experience intrusive thoughts, hyperarousal, hypervigilance. And those intrusive thoughts can even include vivid images of their imagination of what happened to that person. We'll talk more about how to prevent, strategies for preventing or taking care of secondary traumatic stress near the end.
So that's a brief introduction about what trauma could be, a very broad definition of all kinds of things that could be experienced as traumatic, from the individual all the way up to the societal levels. And trauma is a very heavy topic. It carries a lot of weight, and it's very difficult to be a healthcare professional oftentimes because of what we are witness to: pain and suffering. And so for me, what's helpful is thinking about, what can I do about this? How can I act? How can I respond? What is in my control to combat the effects of trauma in my patients and coworkers and society at large? And what I have discovered as a very helpful tool is this field called trauma-informed care. So I'd like to introduce a little bit about what that is. So next slide, Leah, thank you. Trauma-informed care was developed 20 years ago or so. It's an organizational framework for how to support people who've experienced something traumatic. And we call it a universal precaution, almost like washing your hands before you touch the patient. We apply these principles universally as a means of building resilience for ourselves and for our patients. Very importantly, it emphasizes safety first: physical safety, psychological safety, and emotional safety, and it aims to empower the trauma survivor. Notice that I'm very intentionally using the word survivor rather than trauma victim. For me, what I love the most about this, and what's a very important takeaway, is that trauma-informed care aims to foster healing through safe and collaborative relationships. Healing happens in connection with other people, which is beautiful because it means that every interaction you have with a patient is a blessed opportunity to reverse the negative impact of trauma. You all have the capacity to communicate care, to offer love and healing through a patient's recovery. Your, let's say, 15-minute encounter with a patient can be super transformative and really positive and memorable in that patient's life as they recover from their trauma. Next slide. These are SAMHSA's 4 R's of any trauma-informed organization, trauma-informed program, trauma-informed policy. We aim to first realize the widespread impact of trauma. We then aim to recognize the signs and symptoms in ourselves and in our patients and staff. We aim to respond by putting trauma-informed measures into practice, both now and in the long term. And finally, and importantly, especially as we discuss the physical exam later, we aim to resist re-traumatization. We try to not we try to reduce the risk of patients feeling activated and triggered in the healthcare environment, remembering something bad that happened to them in the past and feeling uncomfortable now in the present. So you can see how there's safety throughout the structure of a trauma-informed approach. And next, we'll show you again from SAMHSA the 6 principles of trauma-informed care. And I'd like you to keep these principles in mind as we proceed through the rest of the talk, because they can be applied to everything you do. Trauma-informed principles can be applied to the physical exam, to communication with patients, to the way you do the interior design of your exam rooms and hospitals. It has broad applications. So number 1 is safety above all things. Number 2 is trustworthiness and transparency. We aim to be clear and transparent throughout the healthcare system. 3 is peer support. That's about all of us connecting with one another as survivors, sharing our pain, sharing our healing, helping one another. 4 is collaboration and mutuality. You are partnering with patients. There is a leveling of the power dynamic, power differential that exists sometimes between patient and clinician. 5 is empowerment, voice, and choice. You want to hear the patient's preferences. You want to put them first. The treatment plan will be guided by them and their choices. And 6 is attending to cultural, historical, and gender issues, which is a very broad, very important, very difficult topic to address. And we welcome you all to ask questions or provide suggestions for any one of these principles as we proceed through our talk. We will be allowing for adequate time for discussion at the end. I think someone is unmuted. Thank you so much. So now we're going to just briefly mention, what does trauma look like? How can you recognize it when you see it? What are the manifestations of trauma in your patients? These are the things that I commonly see. I'm what's called in the United States a primary care physician. I practice general internal medicine, so I'm a regular doctor for regular things. And one thing that I see is avoidance of routine primary care. People want to avoid a pelvic exam. They're not going to schedule their colonoscopy. They're going to put off going to their dental appointment, even though they have pain, because the mouth can be a very sensitive area. Number 2, they may not show up to their appointments. They may cancel their appointments where they think, oh, I'm going to get a rectal exam. I don't want to come to see my doctor. They can have vague general symptoms that persist for many years. For example, chronic headache disorder, chronic pelvic pain, where all of the testing has been normal and nobody knows what the cause is. They may avoid disclosing symptoms to you that may prompt an invasive exam or test. For example, they may not tell you that they've been having rectal bleeding. They could appear nervous or distracted during the appointment. They may not adhere to the treatment plan that you recommend, or you could see that someone has very severe chronic disease in multiple organs. For example, somebody in their 40s who looks like they're in their 70s and has had many medical procedures and surgeries, etc. I'll leave this to Leah now to chat about the way that PTSD can manifest, post-traumatic stress disorder.
Chart is a helpful tool for diagnosing post-traumatic stress disorder. So it depicts the diagnostic criteria according to the DSM. So at least 6 months after, this is about at least 6 months after the event, is when you start talking about PTSD. Prior to that, we're talking about acute stress reactions, which are really pretty natural responses to catastrophe. Whereas once you get past 6 months, we're starting to think about, is this persisting longer than ordinary? And might treatment be appropriate? So at least 6 months after the event, we'd be seeing intrusion or re-experiencing symptoms associated with the traumatic event. such as nightmares or intrusive memories. Those intrusive memories can even feel as though they are happening in the present with very real feeling, visual, auditory, and physical experiences. We'd be seeing some sort of avoidance of trauma-related stimuli. So anything that reminds the person of the traumatic event. Some of those triggering stimuli may not actually make any sense to the patient. They may not even be able to identify them because sometimes that kind of information can be encoded in the body and not available to the conscious mind. We'd be seeing negative alterations in thoughts and mood associated with the traumatic event. So you might be seeing some depression or high anxiety. You might see isolating, social withdrawal, loss of interest in things people once enjoyed. And finally, you'll see changes in arousal. So an exaggerated startle response sometimes, hypervigilance, difficulty concentrating, irritability or reckless behavior, and oftentimes sleep disturbance as well. And we want to see these symptoms persisting for about a month.
One thing that comes to mind for me as I'm looking at this table in the third column is negative alterations in mood, loss of interest, and withdrawal. This can often show up if we're talking about mental illness as depression. And so it's important to note that not all people who are looking down and feeling down are just depressed, for no reason, or should be treated with just a medication and that will solve the answer. So through curiosity and your generous time, it's important to further question how or why this might be happening. And so we're going to talk soon about screening for trauma too.
Really glad you said that because in primary care where I work part-time, about half of the depression referrals I get end up being something more in the trauma realm once we do closer evaluation. So that is a nice segue into trauma screening. So trauma screening or traumatic stress screening, both, are an essential part of trauma-informed care, not only because we need this, of course, in order to identify our patients who are suffering from PTSD, but because the act of assessing traumatic stress can actually be a profound intervention in and of itself. First, I'd say simply by asking if someone has experienced a traumatic event and then taking the time to ask about traumatic stress, we're validating the lasting, profound, but often invisible impacts of violence. It goes without saying that time is precious in a medical visit and that you choose to talk about things because they're important to a patient's health. So what message does it send when you take that precious time and you spend some of it talking about how the patient is doing in light of something terrible that happened? It's really powerful for the patient. These are a few screeners that we have access to, and I'm not sure about what languages. I know that they, in terms of the main languages that our patients here at Cambridge Health Alliance speak, we have access to many of these screeners, but I'm not sure for locally what types of trauma screeners are validated. It's something that would be good to look into. We're going to dive in and take a closer look at one of these, which is the PC-PTSD-5. It's a 5-item screener, or sort of a 6-item. It was developed in VA primary care clinics. And the first thing that happens is patients are asked if they've ever experienced a traumatic event, and several examples are provided. This could be spoken to the patient, or it could be handed to the patient for them to read, depending on their situation and what's best for them. And it says this, it says, sometimes things happen to people that are unusually or especially frightening, horrible, or traumatic. For example, a serious accident or fire, physical or sexual assault or abuse, earthquake or flood, war, seeing someone killed or seriously injured, having a loved one die through homicide or suicide. Have you experienced this kind of event? It's not asking them to, it's not making them share which event. It's not asking them to share the details of the event. It's just asking, has something like this happened to you? And if they say no, you're done for that visit. If they say yes, you move on to 5 questions. And they are all yes or no questions about PTSD symptoms experienced over the past month. This is another example of how screening can be a profound intervention. Within these questions contains vital information, symptoms. The fact that these experiences are symptoms offers context to something that may have been experienced as truly maddening in isolation. Many traumatized people believe they are going crazy. They don't know what they have. They don't know that they have an invisible injury that is no less real than a broken arm. And when they see that there is an official term, PTSD, with official symptoms that can explain what they've been experiencing, it can sometimes lift just a little bit of the shame that they've been carrying. And shame is really the biggest antidote to healing. Shame
reduction.
Shame reduction. Yeah. Shame really does thrive in isolation. So we have to talk about this stuff out loud and with as much compassion and confidence as possible. Just tough, take some practice. So the psychometric properties of this scale have been validated in a military sample, and it uses a cutoff of 3 items endorsed. So if somebody says yes to 3 or more, we consider that very likely to meet criteria for PTSD. And it was accurate in correctly diagnosing PTSD 95% of the time when compared to a clinical interview. Now, another way that you could screen for trauma is simply by asking a question like this and not necessarily using a standardized measure. So this is one of Dr. Elisseou's ways of screening for trauma by just asking, many of us have experienced something difficult, whether in childhood or later as an adult, that has had lasting impact on our physical or mental well-being. Do you think that's relevant to you? And if they say yes, following up with, is that something you'd like to speak more about today? I love this question because it's really respecting the patient's autonomy. It's saying, this matters to me, I'm bringing it up, but it's up to you whether we go any further here. So it's respecting their choice, which is a key part of trauma-informed care. So this next tool is called the PCL5. It's a PTSD checklist for the DSM-5 criteria of PTSD. It has 20 items. And I'm really only presenting this because when I've given these trainings to primary care clinics in the past, I've been told that people really want a way to monitor symptoms in response to their own interventions, especially when their patients don't have access to mental health care. So this checklist is a way to do that. You can give this to the patient and get a severity score of their symptoms. And if there is a change, a 5 to 10 point change in their score, it's considered a reliable change. So you might, begin working with them on something, offer some intervention related to their trauma, and then check back in with the scale again in the future and see if anything has shifted. You are still on mute.
We've spoken a little bit about trauma and the principles of providing care that is trauma informed. We shared about how to screen for trauma and how to potentially monitor the effect of treatment by checking symptoms of PTSD over time. So When you do screen for trauma and people tell you the horrible things that they have experienced, sometimes we feel as healthcare professionals stuck, like, oh my goodness, that is a lot of important, very challenging information. What do I do now, right here in this second? So I'd like to share with you some possible phrases that we might use to help us know what to do next. The first here in green on the upper left is just sitting in silence. Sometimes just being there is exactly what you're supposed to do for that patient. Sitting there silently as they cry, as they vent, as they share, just being there. Provide space for their emotions. You may be the only person in their lives who is there just sitting and listening and allowing them to say, I am scared. I feel helpless. I just want to cry. And that in itself is an act of love and great care. You can thank them for sharing something immensely personal and difficult, because it takes a lot of courage to share tough stuff, especially, as Leah mentioned, because this is wrapped in a lot of shame. There in yellow, use your nonverbal skills to communicate care empathically. You want to make sure that your body posture is open and turned toward them. You're not closed off. You're going to provide appropriate eye contact. You're not going to be distracted doing other work. Make sure that you're speaking at an appropriate volume, no loud noises, etc. Here in the center of the screen in blue, explore their resilience. You can say, my goodness, what has kept you so strong through all of this? I wonder, what do you think is responsible for your getting up every day and still showing up for your family? How have you been able to do it? What is right with you rather than what is wrong with you? In purple, we write here, be an advocate. You have a powerful position in your role as a healthcare professional, whether it's a doctor or psychologist, social worker, or any other role that you play. You are able to advocate within healthcare to be an agent for change, structural systemic change. You can provide verbal expressions of empathy, and I'll give you an example of one way to do that well. And you can partner with the patient for next steps. It's not up to us as the doctor to say, here's what you need to do next. The patient knows their life best. They know their symptoms best. They know their circumstances and their needs best. And you can ask them, what do you think the next step should be? And if they say, I really don't know, that's an opportunity for brainstorming together. But the next steps should really be patient-led, patient-preferred. So I'd like to show you one tool here that I really love as an opportunity to make verbal expressions of empathy. This here is the NURSE acronym you see on the left, NURSE, and it stands for naming the emotion the patient's experiencing, express understanding, offer a statement of respect, tell them you support them, and then if there's time and if you're interested, you can explore it further. So I'll give you an example of what I can say in a string of sentences that may express care. I can say, wow, this has been a really frustrating time for you. I can understand how you'd be feeling that way. It sounds like you're just doing the best you can. My only role is to support you. And then you pause. I remember the first time I used this tool, I was covering a colleague. I saw a patient who was practically vibrating. He was so angry, so in pain. And when I said this, his shoulders dropped and he wept. And he said, nobody has ever spoken to me like that. Will you be my doctor? And time again, this works like magic. Why? people want to be heard, they want to be seen, they want to be valued. And so in the space of, I don't know, 15 seconds, you can really make a transformative impact. Next slides. Let's see what's next. Sometimes we're at a loss for words. What can I say? Can you show me some examples? And so one thing is, thank you for sharing that with me. There should be an opportunity of thanking the patient for trusting you with the honor of that private information. It's a huge honor that we have as clinicians to be witness to these private things. You can say your feelings and reactions make total sense. Of course, given what happened to you, this is very normal. We're all human. You can say, I'm amazed that in spite of all you've gone through, you're still managing to go to work, provide for your family, come to this appointment, get dressed in the morning, take a shower. What has kept you going? And you can say sometimes talking about these things can bring up some difficult feelings. It can help to come up with a support plan. Can you think of any supports you can put in place for yourself today and tomorrow? Would it be helpful to speak to your wife about this? Would it be helpful to reconnect with an old friend? Would it be helpful to cook with your grandmother? Would it be helpful to sing a song or go to church or pray? And one of the things that I struggle with as an internist, I am not a trauma therapist. I have no training in psychology. I have no training in psychiatry. There's a balancing act between being open to receiving what the patient has to say and wanting to put some boundaries on it. How can I contain this so that I am not damaged by their sharing? Because you need to preserve yourself going from patient to patient to patient. There's a lot that you can get weighed down by from the stuff that you see. It's almost like you're carrying an invisible backpack with all of these rocks. And sometimes what you see and hear about is just putting more and more rocks in that backpack. So, one thing that I struggle with is wanting to hear what's going on with the patient, but also put some limits. And so perhaps Leah can share with us how she does some containment.
Yeah, this is something that comes up a lot because we're aiming, when we're doing a trauma assessment, we're aiming to access some of the information about what happened to the person without completely overwhelming them and ourselves. So if someone is becoming unresponsive or inconsolable during a discussion about their trauma, it's likely time to compassionately observe what's happening and do some grounding, what we call grounding. So I'm going to offer some examples of how to do that, including how to interrupt, which doesn't feel good, a conversation and intervene when this is happening. So this is an example of what I might say as the provider. I might say sometimes when we talk about traumatic events, it can bring up a lot of overwhelming feelings, or the opposite can happen and we start to feel numb or disconnected. Sometimes people even shift back and forth between those two experiences. What are you noticing right now? So what I'm doing is I'm actually teaching them so many skills by saying that, because I'm telling them a little bit about traumatic stress, which is that going back and forth experience between numbing and flooding. But I'm also helping them shift towards observing what's happening now. So it's mindfulness, and it's also getting to know themselves and building some interoceptive awareness. This is actually emotion regulation skill building in action. So the patient might say, I'm feeling kind of panicky, or I don't feel anything. Like they might look very disconnected and numb. And then I might say, I have a tool that can help when you're feeling that way. And I'd like to teach it to you now so that you can use it anytime you need to when this happens again, because it's probably happening to them many times a day. These tools, which I'll share a couple of in a moment, are pretty quick and don't take very long to teach, which is nice. And they go a long way. I want to show you or introduce you, if you haven't been introduced yet, to the window of arousal tolerance, which is a key tool in trauma treatment. So what we have here is a chart showing a range of arousal from hypo to hyperarousal with this zone in the middle. Some people call it the zone of resilience. It's the space in which we can experience some stress and still feel like we have our 2 feet on the ground and like we can think. Hyperarousal is when we are experiencing a high sense of threat. We might feel the need to run or just have a lot of stress hormones pumping through our system. We might feel really tense, that fight or flight experience. In hypoarousal, it's sort of the opposite. It's this experience of feeling numb or empty, dissociated, disconnected, immobile, frozen. And then, like I said, in the middle, I sort of described it already, sort of the feeling of feeling actually quite grounded despite having a certain amount of stress.
And Leah, could you share how patients may appear or look or behave in these windows?
Yeah, so somebody who is hyper aroused, their leg might be shaking up and down. They might be fidgety. They might be having a hard time sitting still. They might even be pacing. Their eyes might be darting around the room. One thing about hyperarousal is some people will appear perfectly still and actually be experiencing quite a lot of distress internally. So you can't always tell just by their movements. They might be speaking more quickly. They might be more reactive. Somebody who's hypoaroused, their affect might be a little off while sharing information. Like you might think that they would be more upset based on the things they're sharing, but it's more of a blankness, maybe a staring off to the side, not looking at you. That's how I might, some common presentations, but you could really see quite a range. The average patient is going to be on the upper end of the window of tolerance. Like even if it's in the zone of resilience, they're still going to be on the upper end of that during a medical visit, because going to a medical visit is often stressful for people. For patients with histories of childhood abuse and neglect, or who have experienced interpersonal violence, going to a medical visit is often so distressing that they become hypo aroused, often vacillating between the two during a visit. And as a medical provider, we are caretakers. And many people have been harmed by the very people who were supposed to protect them. When you add in other power dynamics that are rooted in structures of oppression, a doctor's visit can become a perfect scenario for traumatic re-experiencing without you even doing a thing. You don't even have to open your mouth and people can feel quite re-traumatized. Luckily, there are lots of ways we can actually support moving patients and ourselves, because we can also get dysregulated when we're with a patient who's dysregulated, into the window of tolerance. Sometimes it's possible to have things shift for the better in a single visit, like in a couple minutes. And other times it can take many visits over a long period of time with intentional work toward creating that safety to make it possible for a patient to eventually be able to come to a visit and feel safe. Two of my go-to quick grounding techniques. One is just statements about the orienting statement. So where am I right now? What day is it? My favorite is how old am I? Because a patient who's being re-traumatized to childhood trauma will often feel almost like a child again, like really young and unsafe and without agency. So I will introduce these statements. I'll say, this might sound really weird, that what I'm going to ask you to do right now, but it's a skill called a grounding skill that is really weirdly, magically effective in helping with traumatic stress symptoms. So just humor me, if you will, and let's try this. I'll do it first. Where am I right now? I'm at the primary care clinic in Cambridge. Today is Thursday, April 14th. You know, it takes a little work for me to like think. I'm getting my brain back online a little bit. What is the month today? What is the year? And how old am I? How old am I? 34 years old. Then the other skill, which I actually use more often, is just naming 3 things that you see, smell, hear, and feel physically, and saying them out loud. And people, when I introduce this, often are like, what is this person doing? Like they really feel a little bit baffled by my behavior, asking them to do this. But by the end of the exercise, almost everybody will report feeling a change in their physiological state. So I name out loud with as much specificity as I can muster 3 things I see around me. Smell is a tough one, but we try to get a couple. And then hear and feel physically. Like I feel my feet on the ground. I feel this chair. I feel my hair on my neck, right? And maybe taking some deep breaths while we do this. So I'm going to introduce you just to the very basic, like broad strokes overview of the gold standard of trauma treatment in the US, I would argue, which is this triphasic model of treatment that Judith Herman came up with. She has that book I mentioned earlier, Trauma and Recovery, which I recommend. Any provider can support this first stage of treatment. This is the focus. Stage 1 treatment, establishing safety and stability. This is all about personal safety, self-care, emotional regulation, and shame reduction. Another key part of stage 1 treatment is psychoeducation, which you're doing by introducing traumatic stress, by screening for it and talking about symptoms and talking about grounding. That's all stage 1 trauma treatment. These other stages, stage 2 and 3, that are about kind of exposure work and processing the details of the events, those are things we don't recommend our medical providers do, because they do take a bit of like training. So unless you're going to go and get some pretty extensive training in that stuff, I would stick to this stage 1 situation, which is in and of itself very healing. So we talked about, like I said, we talked about psychoed through screening, but I also like to have patient-friendly handouts and information that I can offer somebody about the fight or flight response, about the relaxation response, and about the window of tolerance. So these are just 2 pages from one of my favorite little booklets for, it's actually 4 patients that I have on hand all the time. It's called, this one's called Calm Ground. But there's lots of patient-facing info out there that can be really useful, especially if you pull out stuff that's really good and talk to them about it and hand it to them so they can keep reflecting on it on their own a little bit. All right, I'll talk to you about the post-traumatic stress response cycle. So one thing we can do is teach patients to become aware of this cycle and interrupt it. This is the cycle of getting triggered. So having some reminder of the trauma, experiencing a rush of adrenaline or cortisol in the body. People often feel like their head hurts. They feel their heart pounding. They feel shortness of breath. They can feel actually all sorts of physiological sensations. It's pretty wild. Shoulders and neck can become tight. And then that pain and that uncomfortable, all that discomfort can actually continue the cycle because it's distressing. And round we go. But there are ways, like I said, of doing something called completing the stress response cycle, which is a way of exiting this cycle, which I'm going to show you some of those strategies. So here are some examples: mindful breathing, any kind of physical activity, just exerting oneself for even a minute, some kind of creative expression, crying, laughing, physical affection, some kind of positive social connection. Shaking is something that can be quite helpful for completing the stress response cycle. So I want to explain briefly why this works. When we face an actual threat, so not a trauma trigger, but an actual threat in real time, the stress hormones that pump through our body are there for a purpose. They help us to run or fight or stay perfectly still in some cases. Say we flee from that danger and we run towards home. We're out somewhere, there's a danger, and we start running towards home. We've just used that adrenaline for something. We've expressed it. Then we get home, we find our loved ones, we share what happened, they embrace us, maybe we cry, maybe we shake. I don't know if you've ever been through a really dangerous situation and then afterwards found yourself shaking and you can't stop. That's the body doing what it needs to do to heal, to recover. And really all of those experiences help with that, from the social connection to the embrace, to the movement, to the crying. One thing that can profoundly interrupt this natural healing that happens when we let our bodies do what they're supposed to do is when there's a particular trauma that is stigmatized, such that people are too ashamed to talk about it. Then they suffer alone and are much less likely to recover. So lastly, I just wanted to share with you some of the interventions that I teach my fellow therapists to use in primary care. These are all considered stage 1 trauma treatment interventions that can help people move towards safety and stability. Like we actually discussed many of these, but I just wanted to lay them all out. So we've got psychoed about trauma. We've got those grounding skills, and normalization and shame reduction happens. It's like baked in to the screening and the psychoed, and maybe just, a sentence of compassion. If somebody's dealing with current day threats to their safety, it's essential to talk about how to build safety and safety plan. Teaching problem solving skills is behavioral activation. I'm referring to helping people identify the things that they once did that brought them joy and make a plan to do those things. Any kind of empowerment and assertiveness training, which is often around communication, conflict management, and instilling hope every single time you meet with somebody, instilling hope. That can be done just in the interaction. You don't have to even do anything sometimes, but I'd say one way to instill hope is to let people know that what's happening to them is an injury. It's not a chronic, it doesn't have to be a chronic illness. It's an injury that can be healed, just like many other things they come in with. And we're gonna get there. Just saying something like that could go a long way. On to you. Oh, I'm gonna stop presenting, okay?
I think I'm sharing screen already. So this next section, we're switching gears a little bit to talk about a trauma-informed physical exam, but I do want to just give everybody a little break, just 30 seconds. Empty the mind, stretch, deep breath in and out. I'll pause for another 20 seconds or so, just a little break. Okay, That feels good to me. Thank you all for the pause. So my story is that when I started my clinical practice, I realized that there were things I was doing on the physical exam that were making my patients visibly uncomfortable. I remember swinging my stethoscope off my neck and the patient jumped. I remember approaching them for the thyroid exam and they shook back like this. So I started adjusting my speech and my behaviors with the hope to set them at ease, make them more comfortable. And one day a medical student asked me to teach her more about my trauma-informed approach. I had never heard of that before, but I thought it was extremely interesting. I read more about trauma-informed care and I developed a formal framework for a trauma-informed physical exam. We were able to publish it. If you look online, just search for trauma-informed physical exam. The curriculum is available, and I've had the honor of being able to teach this at medical schools across the United States. So I'm going to share an abbreviated framework for what this is. We'll talk about what to do before the exam, what to do during the exam, and how to close after the exam. I'll share that this is very much a guide. These are suggestions. They're not required. They are not meant to be performed in a certain order. I have not tested this. These are just thoughts that I would like for you to experiment with. You can ask questions about it. Maybe they will work in your own environment and culture and country. Maybe they won't, but this is stuff that I am trying to practice with my patients. So before the exam, we make sure that our nonverbal communication is appropriate. What does that mean? We speak clearly and slowly at an appropriate volume. We appear engaged and pleasant and calm as much as we can. Appropriate eye contact. We stand or sit at eye level with the patient rather than them sitting down low and you standing up above them. Avoid sudden movements, keep hands out of pockets so they know what you're carrying or not carrying. Pay attention to what the patient's doing. Are they looking tense? Are they breathing quickly? Are they crying? Are they distracted? And if so, you can pause and just ask about it. Ask, I notice you look very tense. Can you tell me more about that? We set an agenda for the exam, and I'm going to ask Leah to read what's in these little bubbles. This is sample phrasing for something you might say.
I'd like to transition to the physical exam. We will be doing a pulmonary exam today, so I will be listening to the lungs.
This way, the patient knows what to expect. Next, we make it standard practice.
This is something that I do with all patients who come in with symptoms of a cold.
It's not being done for no reason or just for fun. You identify if the patient has any concerns before you do the exam.
Do you have questions or concerns before we begin?
Ask about their comfort.
Is there anything I can do to make you more comfortable?
And finally, offer a chaperone.
Like anyone else to be present for the exam.
And this is something that I find very relevant in the United States. Wibitu looks like you're, yeah, thank you so much for reading yourself. So in the United States, many institutions like hospitals require a medical chaperone for women who are getting a pelvic exam or breast exam. All of my patients happen to be men, and they are the ones who taught me about the impact of sexual violence. So we need to think more broadly about medical chaperones and for whom they're appropriate. During the exam, we attend to appropriate draping of patients. Leah.
In order for me to do an accurate exam of the lungs, I'll need to listen with the stethoscope directly on the skin.
And again.
I'm going to leave the room and allow you to change. Please remove the shirt and you can keep the bra on. Here's a gown for you to wear. It opens in the back. This is a drape that you can place over your lap like a blanket.
And again.
I'll be back in a few minutes. I'll knock before I come in.
So draping is very different in different parts of the world and in different places where we work. I try here to be very specific with my instructions and very clear. I allow the patient to move their own gown or drape or clothing rather than me doing it for them. It's theirs, it's not mine. For a limited exam, you can ask the patient to move their clothing rather than completely getting undressed. Like if they have a spot on their low back that they want you to see, they can lift their own shirt rather than taking off their shirt and pants and everything else. It's best to give them privacy when they dressed and undress. Some places may have a curtain or a divider or a door for that, and try to expose only the minimum body surface area at any given time. We shouldn't assume that all men are comfortable taking off their shirt and being naked in front of others. We should provide tissues or paper as needed following any exam where you use lubrication. We try to knock before entering a patient's space and make sure that the patient says it's okay for you to come in. We introduce each exam component.
I'm now going to listen to the lungs using the stethoscope.
And explain why it's being done.
This is important because we need to see if you have pneumonia, which is an infection of the lungs.
We're giving a medical reason for the exam. The exam's not being done so that you can touch them or look at their bodies. It has medical purpose. Ask permission before touching sensitive areas or moving their clothing or draping.
May I open the gowns from the back slightly in order to get a more accurate listen to the lungs?
It's about doing an accurate exam, a thorough exam, and an exam that will be helpful for you to make a diagnosis. We stay within the patient's eyesight.
And at your side.
And I'll show you some examples of what this looks like. Many people think if I have to listen to the back of their lungs, I should stand behind the patient. But she can't tell where I am or what I'm doing. And so I still get the same information standing at her side. The stethoscope is long, it reaches, and now she can see where I am. Here for generations, doctors have been trained to do the thyroid exam standing directly behind the patient with the fingers fully wrapped around the neck and the thumbs in the back. And that can feel like strangulation. So why not stand at the patient's side with the fingers fully extended on the neck? Tell the patient what you're about to do and why. If you feel like you can't get accurate information that way, you can try an anterior approach from the front. For the pelvic exam, having the patient completely flat is a subordinate position and can trigger memories of abuse and assault. So we can, if the room allows for it, you can put pillows behind them, or you can elevate the exam table 15 degrees, 20 degrees. You can also offer them a mirror for the things they cannot see if that's available in your space. There's even a movement towards self-insertion of the speculum for a pelvic exam, meaning the patient puts it in on their own. There's a movement towards self-insertion of swabs for a non-speculum exam, and even self-insertion of the transvaginal ultrasound probe when you're doing an ultrasound inside the vagina. We try to respect personal space. I'll show you an example of this. When we're listening to the front of the heart, you don't necessarily have to be in front of the patient pushing up against her knees. You can still stand at her side. When we check the heart rate, try to keep your hand away from the patient's genitals. You can move their hand. They can move their hand to rest on their knee or next to them on the exam table. When you're checking blood pressure, in the first picture, I'm pushed up against her knees. She's leaning to the side, having to support her own arm. So I respect her space by standing outside of her space, and I support her arm entirely. We try not to stand blocking any doors, blocking any exits. You can do it for a few seconds, but don't have a long conversation standing above the patient and blocking their exit. Next, we try to use very simple clinical language, and I'll show you some examples.
Mouth open, take some deep breaths in and out.
Trauma-informed language should be very easy to understand. We avoid big medical terms that the patient may not understand. We try to be cautious with whatever imagery we provide. We don't know what could be triggering for the patient. I'll give you an example. We try to avoid any possible sexual connotation. We try to minimize the power differential between the patient and us. We accommodate people who speak other languages as best we can. And our word choice will be professional, not personal. I'll show you an example. This stuff makes sense to me in English. I am not able to translate this to other languages to see if it's appropriate. You would know best. But for my practice, I try to use the word the when referring to body parts rather than your. It feels a little different to hear, now I want to look at your penis, versus I will now inspect the penis. The means it's an anatomic body part that I will examine. I've examined hundreds of other such body parts. It's less personal and zoned in on the patient's body. It's more detached. Instead of saying that this is a bed with a sheet, which can frame the exam in an intimate manner, it's an exam table and this is a drape. Instead of saying, I want to do something, perhaps I'm going to, or would it be okay if I did something? Instead of, that looks good, that looks healthy. Instead of, I want to look at you, I'm going to feel this, I'm going to touch this, maybe inspect, examine, check, evaluate. If a patient appears very nervous and you're going to try to calm them down, we try not to give them any imagery. We shouldn't say, pretend you're just at home, lying in bed. We don't know what's happened to them in bed before, so we try not to do imagery. So you can say, some find it helpful to take a deep, relaxing breath. Instead of shouting at the patient to relax, maybe when you're trying to check their reflexes in their knee, you can say, allow the knees to relax. You're going to give them control over their own body parts. And for the neurologic exam, we hear phrases like, put up your arms like you're going to fight, push me away, don't let me do this. It puts the patient in conflict with the examiner. So just refer to the motion itself. Bend the elbows, push forward, resist this motion, or keep the arms up strong. During the exam, we check in periodically and as needed.
How are you doing?
We use professional touch. I'll show you examples of what that means. I like to place a firm touch on their shoulder when I'm reaching behind them, like if I need to grab the otoscope so they still know where I am in space, even if I've disappeared from their field of vision. And I place a firm hand on the shoulder when I'm listening to the back of the lungs to avoid the surprise of sensation of touch on the body. Prior to an internal exam, a vaginal exam, a rectal exam, you can say, you're going to feel my hand on the thigh to start. You're going to feel my hand on the buttocks, rather than all of a sudden internal penetration, right? Then we try to prepare patients for the sensations they may experience during the exam. You can say, this tuning fork will feel like a vibration. The speculum may feel cold. The stethoscope may feel cold. This will feel very sharp, etc. And finally, be efficient. That concludes the exam. Leah, you can read this part.
Concludes the exam. I'm going to step out now and you can get dressed. I'll be back in a few minutes so that we can discuss your results and come up with a plan together. I'll knock before I come in.
So for efficiency, we can inform the patient how long an exam will take. Maybe you can say, this rectal exam will take 10 seconds. We avoid keeping the blood pressure cuff inflated for too long, as it can resemble a restraint. Take breaks whenever you're doing an exam with a mouth in an open, fixed position to avoid triggering memories of forced oral sex. This is an important reason in our country for avoidance of dental care. And ask patients to show you a genital lesion rather than taking the time to find it yourself. They will be much faster at finding it than you. Finally, after the exam is done, that's when we
knock.
Knock. That's right. Get permission to go back into the room, and we express thanks.
Thanks very much for coming to this appointment and for helping me perform a thorough exam.
Then we discuss results once they're dressed again, not while they're naked, not while they're in the robe, once they're dressed and comfortable and seated in a chair, place of their choice.
The lungs sound clear, which is good news. You do not have pneumonia.
And finally, at the end, you can ask an open-ended question to make sure their questions are answered.
You have.
That's right. So this is just to show on one slide everything that I've shared, how to do a trauma-informed physical exam before, during, and after with our speech and our behaviors. So we'll transition to the final section of our talk today, and we're going to offer plenty of time for questions, for conversation. So this is about self-care, and Leah will guide this discussion.
Okay, you can actually, well, I guess I'll just say it is essential to talk about self-care when we talk about trauma-informed care, because providing care to heavily traumatized populations is very different from providing care to people who have not been traumatized, who are highly privileged. It's different. There are lots of things that can happen to a patient, to a provider, including secondary traumatic stress, like we talked about earlier. So let's go to the next slide to go through some strategies for helping to recover after a really difficult visit with a patient, or a really difficult day, or simply things for prevention of secondary traumatic stress. So if you've had a really challenging, like a particularly challenging encounter, it can be, if possible, it can be really helpful if you can find a calm area to self-regulate and rest between patients. I know that that's not often realistic, so I'm just putting it out there because it could help a lot if there is space to bake that in somehow to your day, or perhaps you just intentionally set aside a little time during lunch or right at the end of the day. It's also, so these are, in case you didn't notice, these are all the trauma-informed care ideas, but applied to ourselves. So in terms of trustworthiness and transparency, it's essential, really helpful, to be honest with yourself about when you're feeling symptoms of traumatic stress. Having peer support is everything. Finding like-minded and empathic professional peers to give and receive validation and support. Maybe you find somebody and you have a conversation about doing this for one another, so that when it does happen, you don't have to go through the tricky experience of trying to figure out who you can talk to about something like this. You've already got them in mind.
And I'll share here, just as I shared before, that healing happens in relationships. I find that this principle, the peer support, is the most important one. So please do look at your colleagues as peer support. You do have one another. Perhaps we can optimize the way that we use one another for supporting ourselves and supporting others. And healing happens in relationships, with your relationship with yourself, your relationship with your family, relationship with friends, relationship with coworkers, relationship with God, relation with your spirituality. So relationships everywhere should be optimized.
The one thing that I understand and that I've learned from Judith Herman's work is that interpersonal trauma heals interpersonally, which is a conundrum, but it's true. and it's also hopeful. So yes, finding ways to connect with peers who are doing similar work like today. And if you're feeling overwhelmed, know that you can ask for support and help as needed. You do not have to continue alone. What you're going through matters. And finally, it's really important to recognize that your identities affect you and are related to the traumatic material you may witness. So you may be getting triggered because of your own identities and your own experiences. And also training, like today, training is, knowledge is power, both for your patients and for you. It builds a sense of empowerment and agency, which is a great way of fighting back against the forces of traumatic stress. You are still muted.
To summarize some of the things that we've mentioned today, we'd like to offer a few closing points. One is that we can all be healers. It's very important to note you do not have to be a licensed clinical therapist to be therapeutic. I'll say it again. You do not have to be a therapist to be therapeutic. We are all built with the capacity to heal ourselves and to participate in the healing of others. Expressing empathy well is a learned skill. We have a lot of it inherently, and you're all inherently compassionate individuals. You've gone into medicine for that reason, but we can all learn some more about how to do this skill successfully. Trauma-informed care is a universal precaution, meaning that we're assuming that the person in front of us has experienced difficult things, and we're just going to go in trying to create a safe space and trying to make them feel empowered and heard and valued. When in doubt and when you don't know what to do next, I find it helpful to pause and tap into a feeling inside of compassion, and whatever happens next is going to be okay. This is a quote I'd like to offer again from Judith Herman. We've been sharing a lot of her work today from that book that we typed into the chat. She says that helplessness and isolation are the core experiences of psychological trauma. Empowerment and reconnection are the core experiences of recovery. So the point is that we will all struggle to a degree in this mortal life. And we not only have to care for ourselves when we go through something difficult, but we have to care for others, because the hard and beautiful responsibility of living on this planet is that we are in this together. So now we'll allow some time and space for discussion. We welcome people to unmute themselves. You can share out loud. You can also share in the chat, either to everyone, or you can send us an anonymous message personally. We welcome whatever you'd like to share and discuss. And thank you so much for your time.
Thank you so much, both of you. Really very good, informative presentation. Dr. Udina, are you there? Maybe you can lead the discussion. There was one question I saw in the chat. Maybe we can start with that.
Yeah, hello, can you hear me?
Yes.
Yes.
Great. Yeah, thank you so much again. It is such a powerful presentation, and you know, I've attended this presentation, but I always learn something new, and it's really powerful for you to share such expertise and experience and knowledge, and this will be many to come, I think, and given the challenges that's going on in Ethiopia. And so I think there was a question about some public health level intervention, and that I think Leah mentioned you shared some information, some tools, screening tools. There's going to be a section on that from Professor Yonas and Dr. Aida, but Leah or Dr. Elisseou, if you want to add to that, feel free.
One thing I'll point out is there's a resource called the Trauma Resource Institute that has a community resiliency model training that I've heard great things about, and I've even heard of it used in the Middle East and around the world by some of my colleagues who work with refugees. And we use it here at CHA as a group model. So I might recommend taking a look at that resource. I'm sure there are others like it out there.
In the absence of finding a training, Leah and I will do our best to compile a collection of resources after this talk, in addition to our slides, that hopefully will be useful to share with patients or your facility at large from a public health standpoint.
Great. Yeah, and we focused, as I mentioned, sharing really extensive background and the experience that you both have at the VA, where we have mostly retired soldiers who have seen so many trauma, and also Leah working with refugees, immigrants with so many trauma, and so we wanted to have that platform to share that experience and expertise. And then Professor Yonas and Dr. Aida will share next in terms of in the context of and the cultural sensitivity in Ethiopia, the next sections.
Yeah, one thing that comes to mind as you mention that is that it really doesn't matter too much what specific event someone has experienced. It all manifests in very similar ways. We have one human brain and one human body. So the brain responds in very predictable ways to severe stress. And the brain governs the health of the body, and then that governs our behaviors. So it doesn't really matter asking somebody, so what happened next, and what specifically happened next, and then what happened next. It's not like taking a history where you want to know the severity of their knee pain and how they twisted it and did it get red and swollen. What matters is how that past event has impacted them today, and that's what you're going to focus on. And healing can happen in any moment. I'll share with you, so I didn't plan to share this today, but it's coming to mind today. So I'll share with you something that happened this week with a patient. He came to me for acupuncture in the ears. We've been trained to do acupuncture in the ears here at the military hospital where I work. And it was for his chronic knee and back and neck pain. Okay, routine. But he said that later that afternoon, he was driving to Vermont, a couple hours away, to visit his son's grave. This man is in his 50s. His son died when he was young from a genetic disorder. The anniversary of his son's death was a couple days prior. The following day was his new son's birthday, and the day when he saw me was his dead son's birthday. So April is a hard month. And he said, we should talk about something else, because he was feeling himself become dysregulated. He was about to cry. So we did the acupuncture, but then I circled back and I asked him, how do you typically celebrate your son's birthday? How do you celebrate your son's life? Who do you have in your life to support you when you are feeling hard feelings? And we talked about the love he has with his wife. We talked about how he used to love working on machines, how he loved to go fishing, but he hasn't done it in a long time. And I encouraged him to re-engage in the things that make him feel alive. And I asked him, what's your favorite color? And he said, red. I remember months ago, a nurse had sent me these little hearts that she weaves with thread, and she sometimes gives them to her patients. I had 2 left in my office. One of them was red. So I gave it to the patient and I said, this is to remind you that your son's memory is eternal. And he thanked me. And 2 days later, he sent me a message thanking me for the heart and letting me know that he put it in the ground with his son, that it felt right to leave it there. And so look at that. I had a basic primary care appointment when I could have just talked about the guy's knee, did what I needed to do and left. But that wasn't the issue at hand. The issue at hand was emotional pain and the need for emotional and spiritual healing. You are all equipped to communicate care and transform a person's day and life. So that's what I wanted to share. And thank you for that space.
Thank you so much again. And as you mentioned earlier, it is so powerful, and anyone can do this, right? Anyone can help. And so it's not just for our physicians, it's not just for medical students. And so anyone can have an impact. And so that is what I really got out of this session. I think there's one question. I think you already answered it in the context and the chat. Given the Ethiopian, what kind of trauma-informed care design you will recommend? If you have any, I think we already touched on this.
Yeah, I think that's a good and complicated question that probably depends on the resources in the community that was most affected, but there are lots of ways that you could apply trauma-informed care to a community.
And we'll circle back with the resources that we have at our disposal, and hopefully something will prove useful and able to be integrated.
One thing I will say is that group care can be pretty wonderful and profound in trauma care, gathering together people who have been similarly affected by an event and creating a safe space to talk about the impact of trauma on present day life and how we can take care of ourselves in light of that. Not getting into all the details of the trauma in a group space, but talking about present day impact and strategies for self-care. That's another way to greatly reduce shame when people see that the things they're experiencing are being experienced by many other people in their community.
Great. And we touched on one of the idea of this session also to make sure to destigmatize and to humanize mental health and mental well-being. And so that's.
I heard something by a trauma expert that really stuck with me. And he said, it's unfortunate that we call it mental health because there's no organ in the body called the mental. This is our brain's health. This is very real. This is tangible. This is happening to you as it would happen to many other human brains who experience severe stress. And so that can be really powerful for people. I've heard many patients tell me, oh my goodness, I thought that I was just crazy. So you're telling me this is real. so you're telling me I'm not making this up? I said, no, this is real and you're not making it up. And even that can be freeing for people.
Just to piggyback off of that, sharing with people that traumatic stress, I think I said this earlier, but just to reinforce, is an injury, not an illness. It's in many ways unfortunate, sort of, that it's a diagnosis. It's clustered with other things that are more mental. So injury over illness, and also, psychiatry, I believe used to be under, at least in the US, it used to be under the umbrella of neurology. So it's about the study of the brain. I think that's a great point, talking about it in terms of a brain injury, which sounds scary, but it's, luckily it can heal.
Great.
I have a question. Probably I'm not in the field, but do you have a different strategy for children versus adult or adolescent in terms of trauma management?
A little bit. A lot of trauma informed care or trauma treatment for children is really family treatment. So you see anything that you would be doing with the child, you would also be doing with a parent, whoever they're caretaking. You'd be teaching the parent about the impacts of trauma on children and ways that they can help the child regulate and help the child gain agency over the difficult sensations that are happening in their body. And there's a lot of wonderful children's books in the US in English that teach children about trauma, that, hopefully there's something similar. And in general, children work through their trauma through play and in indirect ways. When they have a safe space, people do actually heal naturally from trauma when they're given a safe space to exist.
Yes. One thing that I have learned, I don't take care of children in my clinical practice, but when we see children who are shouting or fighting, they're not bad kids, right? These are kids who are becoming dysregulated, and they may not yet in their development or through their experience know how to express it verbally. They may not have been given the language to say, I am feeling angry, I have resentment, I feel betrayed, right? These are tough words. And so helping them to recognize the feeling that's in the body and maybe emotions attached to that, and then giving them tools for regulation, which, as Leah mentioned, is usually through play. Let's color. We love colors. Let's smell the crayons. That's calming. Let's have a tight squeeze and a hug. Let's cuddle with my favorite blanket and stuffed animal. All of that helps them to regulate and be calm and present in the moment. You all know probably that many of us spend our lives living in two places: the past, where we are replaying negative, horrible experiences, or in the future, where we are worried about potentially more horrible experiences. But when are we ever right here in the present, where we actually are pretty safe right now?
Oh, it's great. Any other question people have?
I don't have a question, but I just wanted to say thank you to both of you for such an incredible training. I work in primary care and work at a federally qualified health center where I have a lot of patients who've experienced trauma. And it was really powerful for me to see how we can use things like the NURSE acronym to show empathy, and how just listening and validating feelings and being very intentional about our physical exam can be healing. So I'm in a situation where sometimes our patients, face a lot of barriers and don't have access to, therapist or a counselor or mental health resources. And sometimes I feel stuck. And so it's really nice to see that just listening, just being there and bearing witness to the trauma that people have experienced can be healing. So thank you.
That's it. Thank you for that beautiful comment. It means a lot. For me, verbal expressions of empathy and learning the NURSE acronym, that's the most powerful tool in my toolbox as a physician. It's not my prescription pad. It's not the beta blocker. I think that being present with people and offering empathy is my superhero power.
Yes, and something that we can definitely apply, I think, in Ethiopia in a very resource-limited setting. I know that was a question that came up, but I said just a general practitioner, you can have a lot of power by giving your time and
That's
empathy.
it.
Yeah,
That's
so
it.
thank you.
That's it, because it's love that heals.
Yes.
Thank you so much again, and I'm thinking there's going to be a lot more we will need to do in the future and collaborate and training and workshops, and so I want to thank Dr. Elisseou and Leah, Soumerai again, and then if you don't have any last minute comment, we'll go to the next session.
Thank you.
Thank you so much.
Thank you all so much. Leah and I are headed to clinic, so we'll circle back. We'll see you next time.
Thank you.
Thank you so much.